I'll try and keep us moving here. Um, Thanks to Aztron Medtech for having me on. Thanks to Rich, Stacy Case, Bob Anderson. Love this conference we got going today. I've been tasked to present on ultrasound-guided Achilles tendon repairs. And of course, if you know me, I love to do things minimally invasive. And I do think this is the least invasive system on the market for Achilles repair. And I'm going to show you why and go over some case examples. You might ask, why MIS? Well, it's all the benefits that we see with our bone procedures, these tiny scars. For me, I really like leaving a tiny surgical footprint for my patients. And I also like to mitigate risk. Here's an example, one of my cases from many years ago. This was a open Achilles repair with a V to Y aponeurosis lengthening, probably one of the longest incisions I've ever made in my career. Thankfully for this guy, he healed just fine with his incision. But, when you compare these incisions and the disruption that we do to some of the soft tissues, the lymphatics, the surrounding structures, there's just really no comparison. And again, it's about mitigating risk. Thankfully, that one healed just fine. But then you get some that are a little slow to heal. Here's another one 3 months out post-op, Achilles tendon repair with an FHL transfer, has a couple areas of delayed healing. Here's one that was sent to me, or actually it came to me when I was on call, repair that was done at an outside clinic, deep infection going on, gas going up the back of the leg. These can be major problems and lead to some complications. So it's really about mitigating risk. I mean, you all know where this is headed, cutting out all the bad stuff. And now you're in limb salvage mode. You got to do a split thickness skin graft to get this covered. And yeah, we saved his leg, but is this a good outcome? We weren't really able to save his Achilles, though. So some of the instrumentation you're going to need for this, ultrasound is key. So you need an ultrasound unit. I use a unit inside my operating room that our hospital has, but they also have some options for portable devices. So you can easily do this on an iPad. They actually have ones that connect to your phone very easily. This makes it quite easy to monitor post-operatively. If you want to whip this out and just quickly check your repair in the post-operative period in the clinic, you can certainly do that. A couple other things you'll need. So the Aztron telescoping needle is the needle that you see in the bottom image there. And I'll show you how this works. Also, the 10-min Aztron percutaneous grasper is another key device. So you'll need these things. Typically, some non-absorbable braided suture. I use a couple loop sutures as well as a suture tape. And I'll show you how that works. So then you'll need some bone anchors if you do plan to anchor this into the calcaneus. Just a little schematic here. Essentially, you're going to use your ultrasound to identify the healthy portions of the Achilles tendon. You're going to pass your telescoping needle through that healthy portion. That allows you to pull the suture out the other end. You take your percutaneous grasper through your percutaneous incision and reach up and grab onto the needle. And now you're able to advance the needle and pull that suture out of your percutaneous incision. You do this on the medial side. You do it on the lateral side. And this is how you deliver the suture back into your incision site, and then eventually down to the calcaneus to anchor it. Ultrasound is key for this procedure. I think it does a number of things for us. It helps to identify some of the critical structures that we want to avoid with these procedures because it's all done percutaneous. So the sural nerve, the small saphenous vein, sometimes the tendon has a little bit different morphology to it or shape. So ultrasound also allows you to confirm that you're putting that telescoping needle dead center in the healthy portion of the tendon. There's different levels of the tendon where that tendon changes shape. So you may need to change the angle of your needle. And so if you're not looking at this with ultrasound, you might miss a good portion of that healthy tendon, and your suture is not going to be as secure, and you won't have as secure a repair for your patient. So using ultrasound or leveraging this can be really key to make this procedure successful. I'll go over a little bit of the surgical technique here. Essentially, I use a couple loop sutures that I'll pass percutaneously, like I showed you earlier. You'll pass those ends of the suture through the loop, and this is how you get a locking stitch on your proximal portion of the Achilles tendon. Once you have that done, you can deliver the tails through your percutaneous incision that's usually made right over the rupture site. I also add a suture tape just proximal to this, and I've even had two of these. And then I will pass these down through the percutaneous incision and eventually to the calcaneus to anchor them in. Here you see we have our locking suture in place and just showing how secure that is on the proximal portion of the Achilles tendon. And now I'm checking that suture tape with the sliding suture that's just proximal to those. So I really like to pull on these, make sure they're secure, and make sure that they don't pull out of the tendon before I do pass them down to the calcaneus. And as you can see, you can get a really solid bite with a locking suture and even with the sliding suture with this technique. So here you see we have them pass through our percutaneous incision over the rupture site. Now you make two percutaneous incisions along the posterior medial and posterior lateral aspects of the calcaneus. And this is where you're going to pass them down and then anchor them into the calcaneus. So here we have them down to that area. And now we'll plug them in with a couple bone anchors. And after I plug them in and before I cut the tails, now you can see the tension that we have restored to the calf muscle and the Achilles tendon. And now you can cut your tails and close your percutaneous incisions. And I really like to stress this intraoperatively to make sure everything is nice and secure before we close everything up. But here's your typical incisions. So typically 3 small percutaneous incisions that are left for the patient. And again, we're lowering the risks of wound healing complications, infection, and mitigating the risk for both the patient and the surgeon through this approach. I got a couple case examples I want to highlight with this. First one is a 52-year-old guy that was playing softball and he broke for a ball. And during push-off, he felt an immediate pain to the back of his calf and Achilles tendon region. This came to me a little later, so this was more of a subacute injury. He was actually seen in a sports med clinic and diagnosed with a calf strain at the time. Eventually, he did get an MRI, which demonstrated rupture of his Achilles tendon. His rupture was a little higher than normal. It was about 10 centimeters above the insertion site. So in his case, I actually did not anchor this into the calcaneus, but we did more of an end-to-end repair. So I'll show you just how that works. Usually what I'll do first is do a little survey with the ultrasound before we even get started. And here you can see the rupture site and the hematoma at the rupture site. And then I try and identify the most healthy portions of the proximal Achilles tendon and then the distal Achilles tendon near the calcaneus. And prior to this procedure, I would not say I was an ultrasonographer, but this is a very easy technique to pick up and to learn ultrasound with. This is the largest tendon in the body. So if you're going to learn ultrasound on something, this one is actually, I think, one of the easiest. And as you do it more, you get quite comfortable with it. So here you can see us passing our needle percutaneously through the proximal portion of the healthy Achilles tendon. We'll introduce our 10-min grasper through our percutaneous incision at the rupture site and reach up along the medial and lateral aspects of the needle and then pull our suture through the percutaneous incision. We also, in this case, did the same thing along the distal Achilles because we were not anchoring it into the calcaneus in this case. Some of the more proximal ruptures that I'll treat, I won't bring it down and actually anchor it into the calc, but some of the regular ones or distal ones, I definitely will, and I'll show you an example of that as well. In this particular case, one incision, as you can see there, and we were able to bring the tendon ends back together and reapproximate. And here you can just see the tension that's been restored to the Achilles tendon. And like I said, I like to stress this before we get out of the operating room. And you can see the foot and plantar flexion. Here's that same patient 10 days out. And then eventually at 7 weeks, he's full weight bearing in a boot without a heel lift. So his foot's back to the ground. He's starting to do PT. He's able to do a double heel rise. Here he is at 13 weeks. And at this point, he is full weight bearing. He's outside his boot in a supportive shoe. He's walking up to 2 miles a day for exercise, but he can do a double, and now he can do a single heel rise on the repaired extremities. So this can get patients a very secure repair and also, again, mitigate some of those risks and allow for quicker healing. Saw him at 9 months. He has no limitations. He has full strength. He's back to everything he wants to do. So he's doing well. Second example I have for you is a 35-year-old gentleman that ruptured his left Achilles playing basketball. He went up to jump and felt a pop in the back of his ankle, kind of a traditional rupture, or acute rupture, I should say, of his Achilles tendon. He did not have a MRI, but his x-rays did not demonstrate any fracture. You can see a little bit of dissolution of Keger's triangle back there. So we were able to get to him about 10 days after his original injury. Here's his Thompson's test intraoperatively before we start the procedure, just demonstrating that there's no plantar flexion power to his foot. So we first start with a survey of his Achilles tendon. Here you can see the healthy proximal portion of the Achilles tendon. You can see the rupture site, which is typically heterogeneous in nature, and then the more distal portion of the Achilles tendon. So we identify the normal Achilles tendon along the proximal site. Here you can see our telescoping needle under ultrasound coming in and placing this in the dead center portion of the healthy portion of the Achilles tendon. So it makes sure that we got a nice secure bite on it. So there you can see the needle completely pass through the tendon. And then once we've passed the suture through and removed the needle, you can typically visualize the suture under ultrasound as well. Here you can see we have passed it through our percutaneous incision. We have it down to the calcaneus, and we're about to anchor it into the calcaneus to secure it. Before I do that, again, I like to check the tension and just make sure nothing's going to pull out on me. So here you can see us pulling on the proximal portion of the Achilles tendon and the tension that that's creating. I typically will try and pass my suture through the distal portion of the tendon as well to capture some of that tendon, and then we'll plug it into the calcaneus. And there you can see the bone anchors for where we plugged it in. We'll close up his percutaneous incisions, so typically 3 little poke hole incisions. And then again, I'll check the tension. Thompson's test again. So tension has been restored, foot's in plantar flexion. And we'll push on the foot just to make sure we got a good secure repair before we let him off the table. Here's that patient again, 6 and 13 days post-op, just to kind of get an idea of what the incisions and soft tissues look like, and he's off to the races. So if I can leave you with some final thoughts on this, I think Aztron has a really nice system here, and I think the least invasive Achilles tendon repair system on the market. It offers us all these MIS advantages that you always hear about. I think one of the benefits of this, though, is we can avoid some of those critical structures like the sural nerve, the saphenous vein, and other structures that some of the other systems don't allow us to visualize. It also allows for direct visualization of the healthy portion of the Achilles tendon to make sure that you're making passes through the optimal part of the Achilles tendon when you're doing your repair. And, you know, these are techniques that you have to kind of investigate and I would say practice like any other MIS techniques. So really appreciate the opportunity to go over this stuff with you and hope you enjoy